Good morning. My name is Maureen Kelly. I'm a nurse practitioner, and we're going to be discussing the MOLST form and Advanced Directive Living Will. A little bit about me. I've been a nurse practitioner for 40 years, mainly with the geriatric population, so discussing advanced care planning has been something I've been doing pretty much every day. I've used the MOLST form extensively. I'm a volunteer here at St. John's. I'm one of the parish nurses. Maybe I've checked your blood pressure. I'm also a volunteer on the GiftOfPeace ministry program. The GiftOfPeace is the idea of you giving your family members peace, comfort, by making decisions about your health care ahead of time. We are part of the Conversation Project. Howard County, through the Health Alliance, has a program called Speakeasy to help you have the discussions with either your parents, your children, about your wishes, their wishes for end-of-life issues. We've had large seminars, we've had monthly programs about planning a funeral, life changes, legal issues, estate planning. So you can watch the bulletin for information like that. So we've never discussed the MOLST. It's been mentioned, but no one has gone into detail, partly because you actually need a provider to discuss it, since we're the ones who are signing the form. By using the term provider, a provider can be a physician, a nurse practitioner, or a PA. We're all considered medical providers. We all can sign these forms. So I'm going to start now of what we're discussing today. Today we're going to do an overview of the MOLST versus the Living Will Advanced Directives. Living Will and Advanced Directives refer to the same thing. Some years we use the term living will more, some places use advanced directives more, but when I use one of those terms, it is exactly the same thing. What is and how to complete a living will, we'll go over that briefly since we've discussed that in other programs. I'm going to go over what resuscitation is, MOLST post, how to complete a MOLST form, and what to do with the MOLST form once you have it. MOLST stands for Medical Order for Life-Sustaining Treatment. That means emergency treatment, resuscitation, whether you want tube feeding, whether you want blood transfusions, dialysis, anything in that category. The MOLST, unlike the living will, is a medical order. It's a prescription. And just as if you've got a prescription for a blood pressure medicine, you don't go to the pharmacy and have the pharmacy give you a diabetes medicine, because that's not what was on the prescription. So it's required to be followed, whereas the living will is more suggestions. The MOLST goes into effect once it's signed and you need it. You can be healthy or you can have health problems. I'm healthy. There isn't anything right now that would put me into an emergency room, short of trauma. I did a MOLST form with my provider. The reason I did it is I'm the healthcare person in my family, so I get the phone calls. I get the pictures of my grandson's rashes. What is it? What do I do? So I wanted to give my family peace of mind if I ended up in shock trauma, what they could agree to or what I would want limited to make it easier for them. I was the backup healthcare agent for my parents, and one Christmas evening I had to make end-of-life decisions for my dad. I was comfortable doing it, but it was still stressful. And I can't imagine if you didn't have my background and you didn't have that long conversation I had with my parents of what if, If you had a stroke like grandma, would you want a feeding tube? If your emphysema got worse, would you want a ventilator? We went through all the scenarios I've ever seen in my practice, and I had clear-cut decisions of what they wanted. At the time, there was no such thing as a MOLST form. So when I got to that emergency room, I pulled out my power of attorney, I went through what my dad wanted, and I'm the oldest of 7, my next oldest said, "Oh, I didn't think they would want that." He says, "Yes, we had the discussion, and this is what it says here on this paper." Oh, okay. So we didn't have any family arguments about what mom or dad wanted. It gave me the confidence. It made life a whole lot easier in a very trying situation. The MOLST is nuanced. You can put time limitations. You can say, yes, I would want intubation, but only for 2 days, 2 weeks, 2 months, whatever. This is the only form the first responders, that's the emergency medical system, you call 911, the paramedics come into your home. This is the only form that they can follow. They're not even going to look at the living will. This is their prescription. This tells them what to do. This tells what the emergency room, what they want to be, what should be done. And the MOLST form needs to be signed by a provider. Again, a physician, nurse practitioner, or a PA. It should be signed and it's dated. The living will advance directive goes into effect if you are terminally ill, persistent vegetative state, which means you're unconscious, dependent for all care, or an end-stage incurable condition, so maybe ALS. It's vague, and not all providers will agree your condition meets this criteria. I know of a patient who initially was my patient. She had appointed only her husband to be her healthcare agent. He died before her. She became acutely ill, had internal bleeding. Her advanced directives clearly stated she did not ever want a transfusion. She did not want to be intubated. She came to our hospital, and we saw the will, and the plan was not to give her a transfusion since she had said she did not want it, but not transfusing her would hasten her death. We contacted her son, who said, well, let me talk about it with my brother. When we had interviewed the patient and her husband, the other son was never mentioned as a family member of emergency contact. The other son was a physician out of the area who decided that no, his mother couldn't possibly have not wanted to have transfusions, not wanted to be on a ventilator, and insisted that everything be done. It went as far as the ethics committee, and they basically said, well, we're not really sure she's end stage, we're not really sure she's really terminally ill, she may be chronically ill. So this woman who could no longer talk was put on a ventilator and did receive blood transfusions, and she died a couple of months later. That's why it's vague. You were able to write your general wishes. Your medical provider does not sign it. This can be completed online if you go to speakeasyhoward.org. If you do it online, you do not need to get witnesses. What you will do is put down who your healthcare agents are and their contact information, and Speakeasy will contact them to verify that, yes, they're aware of this and they agree to follow your wishes. If you do use the paper form, you will need 2 witnesses. A witness cannot be your provider. It could be someone in the office, but it can't be your actual medical provider. In my office, I was part of a team, and we had social workers, so social workers could sign it. It also can't be signed by anyone who is in your will, so your heirs can't sign it. Okay, briefly on the living will, you have a right to do your statement of goals and values, what's important to you. I want everything done. I want to be allowed to die peacefully. I want to die at home. I want music playing. I want my dog with me. Okay, here comes the three categories. In a terminal condition, if you're certified that you're terminally ill and death is imminent, you have three choices. One is to keep me comfortable and allow a natural death. Two is keep me comfortable and allow a natural death, but if I cannot take food or fluids, I would want nutrition and fluids by tube or other medical means. Or three, do everything possible to prolong my life and delay my death. Second category is persistent vegetative state. Think of Terry Schiavo, Karen Ann Quinlan. This is someone who's unconscious, can't talk, and it requires all the care of a newborn baby. The same three questions. End stage condition, same idea, same three questions. Pain relief. This is a yes or no. It's not clear from this form. No matter what my condition, give me medicine or other treatment I need to relieve pain. Is that your wish? I have patients who say no to this. They don't want pain medicine because it'll make them groggy. They want to be more awake. I've had patients who feel they need to go through pain just like Jesus did on the cross to purify themselves. Pregnancy, my practice, that never came up. And how you want this to be interpreted by your family. The first is you realize that you can't anticipate all circumstances and they want your family to use this as a guide. Or two, that you realize you can't anticipate everything, but you want them to follow your wishes as listed in this form. And that's if you need signature and witnesses. And this is a speakeasy. Make sure you're heard, even if you can't speak for yourself. We're trying on at least an annual basis to get the word out. We've had a number of people, hundreds of people, come to some of our seminars. What we're trying to work now is getting the sandwich generation, folks who have children, but also now we're also dealing with parents who are getting older. And the speakeasy online, you can get all kinds of information. We can get booklets to help you talk about these things, which are uncomfortable, when to bring it up, what kind of questions to ask. What is resuscitation? Most people have heard of CPR, cardio, heart, pulmonary, lungs, resuscitation, which means bringing you back. If you have no pulse and are not breathing, CPR can be initiated. If you happen to witness someone dropping, have someone call 911 right away, because CPR alone will not bring that person back. Breathing, either mouth to mouth, CPAP, like people with sleep apnea use, or BiPAP, or actually being on a ventilator. I've talked with paramedics up in the Clarksville station, and they're saying because of the advent of the use of CPAP and BiPAP, they've cut down on the number of patients they've actually had to put the tube down the throat to hook them up to a ventilator, that the BiPAP manages them until they get to the emergency room. Chest percussions. The chest needs to be compressed down 2 inches 100 times a minute to be effective. It's not like on the soap operas where they just do a little tapping and within 5 minutes the person's awake walking around. You have to go down with much pressure. Try getting the palm of your hand on your thigh and making it go down 2 inches to get a sense of what that feels like. It is not without problems. If you are a very thin person and have osteoporosis, the pressure may cause some cracking of your sternum, your breastbone, and unfortunately that cracking could lead to some puncturing of the lung, liver. We try our best to get the right locations to minimize that. Defibrillator. With the advent of defibrillations and defibrillator around in various public places, in St. John's, the defibrillator is located on the wall right before the office door in the back of the center. If you have to do a defibrillation, you get the machine out, turn it on, it'll give you step-by-step directions. I'll show you where to put the pads, and if you need to use a defibrillator. The reason for a defibrillator is some people who are in cardiac arrest, their heart is stopping. It's because their heart is beating so irregularly that it can't get blood out. Our left ventricle, the lower part chamber of the heart, is what pushes blood out to the system. Some of that blood goes to the arteries of the heart to keep the heart functioning. The rest goes to our body. If you're having a heart rate of 150 beats a minute and it's skipping, you're only getting little squirts out. You're not getting enough to survive. And the defibrillator can stop that. And obviously being transported to the closest emergency room. Most Americans think that CPR is very, very effective. Unfortunately, the data doesn't show that. This is data from 2000, Academy of Emergency Medicine, of how many survive. They define survival as discharge from a hospital. They did not state whether this was to home or to long-term care. As you can see, 40 to 59, only 10% survived. 60 to 69, 8.1, 70 to 79, 7.15, 80 to 89, 3.3, aged 90 plus, 1%. Doesn't mean that you might be that 1%. My niece's father-in-law had a cardiac arrest in Home Depot. He fortunately did it in front of the staff person who was a CPR instructor for the store. So he got CPR immediately. He's up walking around. His underlying heart issues are being addressed. So he got to see and enjoy his new grandson. Most people who have an arrest have it without somebody around. If he had been in another aisle at Home Depot, his survival rate probably would have been less. If the person is down for more than 5 minutes, there is significant brain damage. MOLST post. Most states have either a MOLST, medical order for life-sustaining treatment, or a POST, physician order for life-sustaining treatment. They're essentially the same. The Maryland form goes into more detail. Pennsylvania is shorter and there's less room to write things in. Our nearby states, Virginia has a POST, West Virginia a POST, Delaware a MOST, New Jersey a POST, New York a MOST, Pennsylvania a POST. States generally follow other states' forms, but if you have one from another state, have your Maryland provider complete the Maryland form just to be sure. If you're not sure if the state your family is in, you can just Google it. It'll come up with a list of states that have it. And you can download it. Okay, let's go through the form. We're going to go through section by section. This is pretty self-explanatory. The top part, your name, date of birth, male, female. And as a provider, I have to check who is telling me this is what they want. Is it the patient? Is it the patient's healthcare agent, guardian, surrogate? If it's a minor, is it the legal guardian, the parent, or is this person under Child Protective Services who is a legal guardian? Okay, here comes the hard part. CPR. What is it that you want? Now, when you're filling these forms out, fill it out based on how you are today. When you're 90, you may want something different. You can change this, but fill it out how you are today. Don't overthink it. I'm healthy. I selected to do CPR. If I had severe diseases, I may change my mind on that. My patient population were usually between 80 and 100 who had many medical issues, and a number of them did not want CPR. So here are the options if you do not want CPR. This is, again, your heart has to be stopped. At no point is this, we're not going to care for you. It's just, what do we do if your heart has stopped? Option A, you can do everything such as even intubation prior to the heart stopping. A2, do not put me on a ventilator, but you may use a CPAP or a BiPAP, but do not intubate. That third option is no CPR. Option B, palliative and supportive care. Prior to arrest, meaning the heart stops. Provide passive oxygen, comfort. If there's bleeding, put a bandage there. If you pick option B, the paramedics do not need to transfer you to the emergency room. This is palliative care. I only use this for my patients who are on hospice. And this is what a lot of people don't understand. A lot of providers don't understand. You need to pick one. Either do CPR or do limited ventilation support. I've gone into homes where the provider has picked 2 or 3. That invalidates the form. There's no way the paramedics can decide do, don't do. They've got to make a decision. The provider needs to sign it, license number, ideally phone number and date. As long as it's signed and dated, the paramedics will follow it. But why not do it correctly? We're going to what is on page 2. Now, page 1 and 2 need to agree. If you've written on that you do not want CPR and you do want to be intubated, when you get to this section number 2, you should have what you put down on the first page. So for my patients who only want CPAP or BiPAP, I would check 2C. If you notice, it says you may use intubation or ventilation on limited trial. You can put in trial limit. I have patients write 3 days, 2 weeks, a month. And again, 2C gives you a time limit if you choose, or no ventilation whatsoever. Blood transfusion, yes or no. If you leave a section blank, it is presumed that you would agree to what is offered in that section. So even though you don't check, may give blood products, but if you didn't check, I do not give blood products, they would offer you a transfusion. Again, this form goes also in effect when you cannot speak for yourself. So if you're alert, you can say yes, no, and you can sign for it. Hospital transfer. Go to the hospital for any situation requiring hospital-level care. That doesn't mean going to the hospital for a hangnail, but if you are sick and it's something you would call 911 for, go to the hospital. The other is you only want to go to the hospital severe pain or severe symptoms that can be controlled at home. 4C is do not transfer the hospital, but treat with options available outside the hospital. Following up on that is number 5 is medical workup. You may perform tests indicated to diagnose and treat what your new condition is. 5B is only perform limited medical tests necessary for symptom relief. You could think of someone with cancer who now has some new abdominal pain, and that's not where their cancer is. They have lung cancer. They only would want tests to try to figure out why they're having that severe abdominal pain. They don't need more chest x-ray. They know they have lung cancer. But they would want to know, is this because I'm having an aneurysm? Is this because I have appendicitis? What's going on? And 5C is do not perform any medical test. Now, if you don't want any medical tests, you're also probably not going to the hospital either. Antibiotics, you may use antibiotics, oral, IV, or in an injection. B is you may use oral antibiotics. C, you only want antibiotics if it's going to make your symptoms better. You have a severe urinary tract infection, and we're going to give you an antibiotic so that burning and pain will stop. But otherwise, you don't want an antibiotic. Or D, do not treat with antibiotics. Artificially administered fluid and nutrition. Again, fluids means IV. Nutrition means some type of feeding tube. 7A is you may give both, even indefinitely. 7B, you may give both, but a time limit. Again, you can do days, months, whatever, weeks. 7C is you may give fluids, such as IVs, but do not give any artificial administered nutrition, such as a feeding tube. 7D, do not provide either. There's a dialysis question. Yes. Yes for a time limit, or do not provide this. Now, if you have selected that you do not want to be resuscitated, if you have surgery, that order is canceled. Because when you are in surgery, you have an IV running. If you're having anesthesia in the OR, you're going to have that endotracheal tube in because they're going to be managing your oxygen while you're unconscious from your anesthesia. You're going to have an EKG going, so your heart is being monitored, and if you start going into irregular rhythms, rapid heart rate, very slow heart rate, medication can be administered to correct that. Once you're back on the floor and you're out of surgery, unfortunately, many times that do not resuscitate order doesn't get revived. So you or your healthcare agent should bring that up to the staff. Oh, remember when I came in here on Tuesday? I want to be sure that gets updated again back to what I wanted before the surgery. I have seen a number of cases where a person was a do not resuscitate, went in the hospital for a hip repair, and went to rehab. And when they went to rehab, since the person who filled out the forms just looked at the order and saw that the do not resuscitate had been canceled, presumed that was the way it was for life, and sent them out as a full code. Everything was to be done. So check that. If you were discharged to a rehab center, a MOLST form needs to go with you. Whether it says do everything or any limitations, it should be there. If you go to an assisted living, they need to have a copy of your MOLST form. Okay. You have a MOLST form. Well, first of all, you've had the discussion with your provider. If you're going to a medical appointment and you're not going to be seeing this provider the next day or two, you need to walk out of that office with the completed MOLST form. Your provider will most likely want to keep a copy and insert it into your medical records. I'm finding with dealing family members, I've gone to providers who they have the discussion, but they never fill the form out. This happened with 3 of my family members. I spent 2 months getting a post form from my father-in-law, who's a Pennsylvania physician. So what do you do with the form now that you have it, it's signed? Don't put it in your safe deposit box. EMS is not going to stop at Bank of America at night to get it out of your safe deposit box. First of all, they're closed. They can't get in. And if you're acutely ill, having a heart attack, you don't have time for that. The MOLST form, especially if you don't want things done, should be posted in one of 3 places or many places: at the bedside, on the refrigerator. They'll look on the bathroom door as long as there's not towels and bathrobes and whatnot on the door. If they do not see the form, again, you've called them for help. You are possibly having a heart attack. They don't have time to look through your house just like you look for your keys. They have to see it right away. They have time limits. They have to act right away. If they do not see the form, you will have full resuscitation. Make copies of the form, because if you do go to the emergency room, that form will go with you, and you won't get it back. So be sure your healthcare agents have copies, you have other copies. The MOLST form is in effect until you decide to make changes. How do you make changes? You can rip it up, you can make an X through it. If you do make changes, be sure you update it with your provider so you have your current wishes. It is recommended that you discuss your wishes with your provider at least on an annual basis. That's what I was required to do in my practice. I also had discussions if their condition changed, if they were getting sicker. They had a new diagnosis, to be sure they understood what their options were and what they could do. So what we're recommending is that you have a healthcare agent, that you have a living will that says your general ideas, and with Speakeasy, your living will gets posted to a living will site. And if you go into Howard County Emergency Room, there's a section they click that will have who your healthcare agents are. So they know if I went to the ER, they'd say, oh, she's got healthcare agents, she's got a living will, she can't talk right now because of the accident, we'll contact them. And if you have anything you don't want, be sure you have a MOLST form and it's readily available. That's the end of my presentations. Any questions? Okay, I'm available to discuss this with you. We could do one-on-one. If you're part of a group, knitting group, book club, small Christian community, if you would like me to come and speak to your group about this form, feel free to contact me. You can reach me through the parish office. And thank you very much for your time, and have a good day.